I'll be discussing the management of seizure. And before we start, I'll just briefly define terms. And so let me just give the outline of the few things we talk about. Number one is the definition of terms, because often people mix things up like seizure episodes, disorders, and epilepsy, non-epilepsy, epileptic seizure, and then also status. So I'll quickly go over this. Now, what we must understand is that when the term seizure is used, so it refers to the cortical neurons. Now, if you have the brain, now this is the cerebral hemisphere, and the peripheral layer of the cerebral hemisphere, that's where you have the cell bodies of the cortical neurons. And so the cell body forms the cortex of the brain. They form the cortex of the brain. So, and they send their axons down, and these axons, they interact with the other neurons. With the brain, that's what we call the nuclei. So the nuclei are the cell bodies within the brain. And so this nuclei, we call it the basal nuclei. And then also, apart from that, interact with other ones, which are the cell body that sends neurons to the face, which is the bulbar neurons. And so we have the cortical bulbar. Those ones that come from the cortex to this cell body that sends neurons to the face. So to face, that's the bulbar neurons. So that's this neuron is called the cranial nerve. So which is very important. So they send nerves to the face. Then they also some goes down to the spinal cord. And this spinal cord, they now make a synapse with what goes to the rest of the body. So, and these ones that goes to the rest of the body, they are called the spinal nerves. So the ones that goes to the spinal nerves are called cortical spinal tract. The one that goes to the bulbar nerves, that's the cranial nerves, are called cortical bulbar. So we have the spinal nerves. We have the ones that goes to the body, which is this cortical bulbar. Sorry, that was a mistake. It's cortical spinal, I wanted to say. It goes to the spinal cord. Cortical spinal. The one that goes to the cranial nerves, we call it the cortical bulbar. Cortical bulbar. So now, in seizure, what we have is a disruption of the brain, and that is due to a form of changes that involves the cortical nerves. So these cortical nerves, they have two things. One, hypersynchronicity. Now, this is more like where you have one nerve able to trigger several other nerves to fire. So usually in the neurology, if you have a nerve, it triggers another nerves, and these nerves can also trigger another nerves, and so the impulse keep going, triggers this nerve triggers. So, but in seizure, you have a nerve triggering several nerves, and so when several nerves are triggered, by this nerve, that's what we call hypersynchronicity. And so that's one of the property, or one of the hallmark rather, in seizure. So the second is the fact that you have excessive discharge from this focal neuron, or the focal neurons, as the case may be. So these focal neurons, they are able to trigger several other parts, but they have excessive discharge themselves. So the excessive discharge occur from these focal neurons. So this excessive discharge is also the second hallmark of seizure. So, but all these occur within the cortical neurons, and the cortical neurons, like I said, they are ones that has the cell body in the peripheral layer of the cerebrum. So when we talk about seizure, we mean when you now have destruction of the brain due to hypersynchronicity and also excessive discharge from cortical neurons. So then that defines seizure. So what you see phenotypically, that is the manifestation of the patient, can either be motor, autonomic, and so when you have the cortical neuron giving a trigger to several neurons, that is hypersynchronicity, and also the excessive discharge of that neuron, if you have the two, the body will have phenotypic features, or let me not use the word phenotypic features. The body will have clinical manifestations, which can either be motor, can be sensory, it can be autonomic. So, however, the source is from the cortical neurons. So we call that seizure, seizure, loosely. But ordinarily, it is said to be epileptic seizure. That's the best way to qualify it, epileptic seizure. Now, it therefore means that we have some seizures that are non-epileptic. So those ones that are non-epileptic, they are the ones that did not originate from these cortical neurons. In other words, there are activities that looks like seizure, but not from the cortical neurons. And the cause are numerous, but common ones include the psychogenic. So we call that psychogenic non-epileptic seizure. So these ones are not due to the cortical discharges. So now, that means if you have a disruption of the brain function due to cortical discharge, that is epileptic seizure. Now, if you have an episode of this, that is a seizure episode. Now, if there is also, apart from this, if there is a tendency, to have a repeat episode, then we talk about a disorder. However, the ILEA has given a better way to define a seizure disorder, which I'll prefer we go by. And then this includes number one, ILEA is International League Against Epilepsy, and they there was consensus in 2014 and the features or definitions of epilepsy, and this is what I would like us to look at. And so we can look at it here. So, and this is from the ILE sites, and so these are the key thing that defines epilepsy. The first one is when you have two unprovoked seizure, and that must be emphasized, unprovoked. If you have a provocative seizure that is triggered by anything like maybe someone who has a stroke, or somebody who has a tumor, or somebody who has whatever things that triggers maybe encephalitis and so on. So you can't say because it fulfills the criteria of seizure occurring greater than 24 hours apart, that's a seizure disorder. No, because you can identify what is triggering it, and so that's not seizure disorder. So it must be unprovoked seizure and must occur more than 2 hours apart. Number two is the fact that you have one unprovoked seizure. This is where you talk about the enduring tendency to have a repeat seizure. And this is important over 10 years. That's if you have the tendency enduring for over 10 years, then you talk about the seizure disorder. That's another way. If it's just an episode where there's an enduring tendency, so that's number two. In this case, you have an enduring tendency. And then number three is when you have a diagnosis of an epilepsy syndrome. And so if you have in any of these three, that defines epilepsy. And this epilepsy is seizure disorder. So this is seizure disorder. So that defines epilepsy, or in other words, seizure disorder. So that's what it defines. So look at this three path. You see that any of these fulfills the criteria of being a seizure disorder. Now we talk about what seizure means loosely, but how it should be better qualified. It should be an epileptic seizure that is coming from the cortical neurons. And talk about the non-epileptic seizure. An example is a psychogenic non-epileptic seizure. And then we'll talk about the seizure disorder, which is also epilepsy. Now, what we'll now talk about now is status, which is also very important. Status epilepticus, so which is now the third term. So when we look at all these terms together, we'll now look at how to manage them and what we mean by the management of seizure. So, what of course, it depends on how the patient presents, and so, but typically, we must first understand the background definition of terms. So, the third one we will look at is the status epilepticus. Now, this is defined based on one, the duration of seizure episodes, two, the number of the seizure episodes. So in the duration, we talk about a single seizure that lasts more than 5 minutes. Or if you have two or more seizure within 5 minutes without a regain of consciousness. So without regain of consciousness. So which is very important. So you can either have a seizure lasts up to 5 minutes, or two or more within 5 minutes without regain of consciousness. So either of the two, we talk about status epilepticus. And the question is, why is it important? It is important because if you have continuous seizure, that means you have brain death. It has cause irreversible brain injury, and also brain death can also occur from that. So you would want to prevent that. So now, having looked into these different terms, we can now look at the patient who has presented in A&E, and then patient presents with, let's say we have a man, 23-year-old, presenting with a descriptive, let's say, seizure type. So in which patient has what looks more like a generalized tonic-clonic seizure, and it lasted, let's say, for 3 minutes. So by the time he's in the air, he is already well. He's stable rather, and you have to review. In this case, the major thing is to observe and then evaluate. That's the major thing to do. Now, if a patient presents in AIE with a repeat episode, maybe, and then you can abort the seizure if there's a repeat episode. And then you can abort the seizure because you will not wait for 5 minutes to confirm if you have a status or not. You can abort the seizure. However, if there's a history, not history right now, but if somebody is presenting with a seizure episode and he's been having repeated episodes without regaining of consciousness and his status epilepticus, because by the definition we gave earlier, that it has lasted greater than 5 minutes, either a single episode or 2 episodes without regaining of consciousness. So if you have that, then you also have to abort the seizure. And in this case, because of the history of it being more than 5 minutes, you know that you are dealing with a case of status. So you have to manage as such. You have to manage with that in mind, that this is status epilepticus. And so status epilepticus, it's more like a form of a manifestation of a seizure, of an epileptic seizure. So if you have status, let's say status, it can be first episode in a patient, and then it can be seen in a patient with seizure disorder. And there are several reasons for status epilepticus. It could be from a patient who has had, for instance, hemorrhagic stroke, can develop first episode of status epilepticus. And a patient with seizure disorder too can have status epilepticus. If a patient, for instance, let's say, stores medication, that's anti-epileptic drugs, or maybe has other things, food and sleep deprivation too. So that also can also be cause. Anything that can also cause it in the first episode, like stroke, encephalitis, and so on. So now, if a patient presents, how do you manage? So we must understand that you are managing two things. You are either managing a patient with seizure episode. You're managing seizure. That's what I want to say. That, and then the underlying cause. That's what concerns you. Like you manage the seizure, which is what patient presents with, which is the acute thing. Patient has seizure, either status or non-status. That's, you want to abort the seizure in either of the case. That's the most important thing. You want to abort the seizure. Then, if you have succeeded in aborting the seizure, you now want to manage the underlying cause. And that's the key thing. Of course, management of the underlying cause, it has to do with evaluation in terms of you have to look for it, and then this will go through history, examination, investigation, and then this helps with the evaluation, find out why, and then of course the treatment. And this treatment, we go with the approach of the medical treatment, and if surgical is applicable. Yeah. So for the medical, we talk about the pharmacological, the non-pharmacological. Those are the ones we talk about. So that will be the approach. So if a patient, like I said, if it's just a non-status in which the patient has seizure episode in the hospital, you abort. And if he has been having seizure from home, and you see suggestive of status epilepticus, he also managed to. So how do we manage, or how do we treat status epilepticus? So that's the next phase we want to look at now. There are 4 important steps that I'll talk about. Number 1 is resuscitation. Number 2 is the treatments of seizure. Number 3 is treatment of reversible causes. And then number 4 is the involvement of the anesthetist. Now, we look at the first one, which is resuscitation. When the patient presents in AI, you want to ensure that the patient is breathing spontaneously. So, in other words, we're trying to talk about the ABC of resuscitation, and that's said to be for pediatrics. And then for adults, we talk about the cardiovascular first, CAB. Cardiovascular first. So we must ensure that you have the patients having good circulation, airway patency, and then that breathing also is spontaneous. That's very important to all forms of medical emergencies. So, and this is very important. And there's this G. They said that's the D rather. Do not forget glucose. So, which is very important. Patient might have hyperglycemia. So that's more like talking about part of reversible causes. So, but for the seizure episodes, there are 3 steps in the treatment, and we have 1 is the use of benzodiazepam. And in this case, that's the use of lorazepam, particularly. So let's just write lorazepam. So that's the use of lorazepam, and which you have to give. That's the first thing to do. Of course, you have to remember that in the resuscitation, you ensure this, and if there's anything, you intervene accordingly. You might have to give oxygen, you have to suction, as the case may be. But it's more convenient if you're able to abort the seizure. So, and that's the essence of the what you give. That's the benzodiazepam that you give. And usually, you give lorazepam, So when you give lorazepam, you must understand that you give it usually 4 milligram and IV bolus as the preferred way to stop the seizure. And if you don't have a response within 10 minutes, you have to give another one, which is very important. So that's the lorazepam. You give another one if there's no response within 10 minutes. Now, if you don't have a response yet, then you want to now start up IV infusion, and that is phenytoin. Usually, it's given at around 15 to 18 milligram per kg, which is very important. So, the first one, we said it's lorazepam, and you give 2 doses. The first one, then after like 10 minutes, you give another dose. Now, and if you still don't have if you don't have a seizure abortion, then you move on to give phenytoin, and it's very important. Usually, full phenytoin is preferred, and 2 reasons: you've got the rapidity in terms of the IV infusion, and then also the lower CNS toxicity. So, and then similarly for lorazepam too, the onset of action is also rapid. Sorry, the spelling is F, not PH. It should be F. Phenytoin. Yeah. So that's it. So, and that is important because you don't want to worsen the patient's problem. So, you want to use what we have, lower toxicity. So, then this is what you do. And if by the time you are you are getting to this point, it's expected that you notify the anesthetist already, so that if you don't still have a control of the seizure, patient can then be taken to the ICU, and then propofol can be given. So, but you must also understand the third part, which is the treatment of reversible causes. For reversible causes, which is the third part of it, what we listed earlier, you must understand that this is very key, and that's why we talk about what you must do. We talk about glucose the other time. That's what you can readily give, and then also you have to consider if the patient has if the patient is an alcoholic, I wanted to say, in which you must consider administration of thiamine to alongside the glucose that you want to give. So, but you also have to look out for other causes that are, reversible. It might be electrolyte derangements. You have to look into that, which is very key. Arterial blood gas. You have to look into that too. So all these are important that you have to look into. So, and by and large, you have a patient presenting in the hospital with seizure, and your goal is to abort the seizure and to evaluate the cause of the seizure and treat. Some seizures are reversible. Some causes are reversible, some are not reversible. But the most important thing is to treat the acute presentation, which is the seizure episode. And this is the algorithm by which you go by treating the seizure episode before you now go on to properly evaluate the primary cause of the seizure. So this is what we have for now. Thank you.